My name's Hayley. I work at Cerebral Palsy Alliance Research Institute, and I'm really, really pleased that you've been able to join us today. And for those people online, I'm hoping that you're able to the chat. For people in the room, if you need to use the bathroom, you can access it through this door here. There is lovely, lovely coffee, thank you JLL, outside, and some wonderful cupcakes at the back as well. There'll be a light lunch served after our session.
So thank you, and I also just want to extend our acknowledgement of the traditional custodians of the land, the Gadigal people of the Aurora Nation, similar to what Uncle Alan said. My name is Andrew Ballantyne. I'm the Managing Director here at JLL New South Wales, and we're very glad that we're able to offer our space for you to use today. You know, at JLL, our purpose is to shape the future of real estate for a better world. And anytime I say that to people, I get this look, what does that actually mean? And it's actually quite timely. Last night, our ESG performance report came out, and there's some numbers in there which I was really proud of. From an environmental perspective, we've reduced our Scope 1 and Scope 2 emissions by 34% relative to 2018 baseline. Also, we get touching on electricity consumption. You know, we're using 29% renewables across our portfolio. So we've still got a long way to go, but we're on the right journey. But what I'm really proud of as an employee of JLL is ultimately what we're doing in that social aspect of ESG as well. Our corporate volunteering days were up 14% last year. Our charitable contributions equated to 1.7% of our pre-tax profit. So we're moving in the right direction in terms of where we're sitting. Now, we're very proud, as I said, to give our space to the Cerebral Palsy Alliance. They're certainly no stranger to us. We've certainly done work with them before. And we're really, as I said, happy to give the space to the Alliance and also CMV Australia in terms of the session that we're having this morning. So thank you. Apologies for the weather today. It feels very like home to me in the west coast of Scotland, and it also feels like June in Scotland as well. Right, but yeah, you're very welcome, and I hope you enjoy the space, and I hope you enjoy the session. And I'll pass back.
Very much. Thank you so much to JLL for so generously supporting this event. We're so grateful. It's just absolutely amazing. And today's going to be relatively informal, even though we're in these very lovely, slightly formal surroundings. In terms of the speakers will introduce themselves and then they'll just do their presentations. If you have any questions, if you leave it till the end of the presentation, that would be fantastic. And if anyone's online on the chat, we're monitoring it. If you have questions, we'll sure to shout them out after the speakers are presented. So without any further ado, I'll pass over to the fabulous Kate Daly and Hanako Stump, who are presenting from CMV Australia. Thank you.
Thank you. Thank you so much, Uncle Alan, for that special welcome. That was amazing. It was quite beautiful. And thank you so much, Andrew, for having us all here today. It's funny, my father was a real estate valuer, so yeah, it's kind of, yeah, anyway.
Probably thinking my sister's a scientist and she would be in hysterics.
Grew up with real estate my whole life. So without...
Okay, I'm going to pull up the slides.
I just had to remember my password for a minute, sorry. It's so lovely to be here today, and it's quite strange because it's been quite a while since we've done anything in person. Kind of used to be behind a screen. It's a bit, you know, safe, feel a bit safe that way. But so good morning, everyone, and thank you so much, Hayley and Kath, and the Cerebral Palsy Alliance for inviting Hanako and I to speak with you today on behalf of CMV Association. Thank you also to Jones Lang LaSalle for generously having us all here in this magnificent space. It's amazing. So I think everyone attending today, whether you're here in the room or joining us remotely, already have some knowledge on what cytomegalovirus, CMV, is. So we'll just review some of the most important facts. CMV is a common virus which is found in bodily fluids such as urine, saliva, nasal mucus, and breast milk. Humans are the only source of CMV, with peaks of infection occurring in children under 2 years of age and during adolescence, with 50% of people having been infected by young adulthood and up to 85% by 40 years of age. Children and adults with healthy immune systems don't usually develop symptoms when infected, but may develop an illness similar to glandular fever with tiredness, sore throat, swollen glands, and fever. The highest risk to the unborn baby occurs when a woman who has never had CMV before is infected with a virus for the first time during pregnancy, and when infection occurs during the first half of the pregnancy. It is important to note that the risk of transmission from children born with disability from congenital CMV is no greater than that from children who are born with CMV without symptoms or from anyone else who contracts CMV infection at any stage in their life. CMV infection is not a notifiable disease in Australia or Aotearoa, New Zealand. Infection with CMV does not affect access to school, work or childcare, including infants who have disabilities due to congenital CMV. There is currently no licensed vaccine for CMV, but vaccine trials are underway.
For most of the family CMV Association represents, the first time they heard of CMV was either when they were diagnosed with it during their pregnancy or after their babies were diagnosed with a disability once they were born. The first time I had heard of congenital CMV was when complications arose at 28 weeks gestation. I had a very normal pregnancy prior to that. Hugh, my lovely husband, was a GP in Orange, New South Wales, and though he knew about CMV, he never knew the profound impact it could have on an unborn baby. With so much information on other causes of disability in pregnancy, there was only one sentence on CMV in his medical textbook at university. And that's something we'd like to help with. While CMV may reactivate while the woman is pregnant, it doesn't usually cause problems to the woman or her unborn baby. Unfortunately, though, usually doesn't mean always. Although my obstetrician and maternal fetal medicine specialist, MFM, believed that I had a secondary reactivated infection, my daughter Beatrix was given a bleak prognosis due to her CT, fetal MRI and ultrasound results. At 28 weeks, I went for a routine ultrasound where extra fluid was found around our baby's heart, pericardial effusion. We were then sent to the Nepean Hospital for a full scan. At this point, we thought our obstetrician was being overly cautious, but we felt confident that everything was going to be fine. Unfortunately, however, they found dilated ventricles in Beatrix's brain, ventricular megaly, which was much more concerning, raising further alarm bells for everyone. I then had a fetal MRI, and I can still remember feeling terrified as I had to lay flat on my back, still in the machine for an hour while they scanned the baby. We left straight after to try to get back home to Orange, which is about 3 hours away, to pick Elodie, our oldest daughter, from daycare. But an hour into our drive, we got a phone call from the doctor with grim news. Our baby had an enlarged liver and spleen, shortened limbs, calcifications, cysts and white matter in her brain. And this was most likely to be caused by congenital CMV. We turned the car around back to the hospital so she could do an amniocentesis. I remember the amniocentesis being extremely uncomfortable and painful. I held Hugh's hand in agony and tears, still in shock, unable to believe the situation that we had found ourselves in. We then had to stay in Sydney in case of any complications after having the procedure, as there was a risk of cramping, bleeding, miscarriage and premature labour. We actually didn't even have an overnight bag, and Hugh had to borrow my dad's undies. But most importantly, we couldn't go back to our daughter Elodie, who we said we would be back for that day. Our hearts were broken in every way. A few days later, when I was 32 weeks pregnant, it was confirmed that Beatrix had congenital CMV and the prognosis was bleak. They couldn't tell us what the outcome would be. However, there was a very high chance that she was going to be born with permanent disabilities, including hearing loss, vision loss, global developmental delay, intellectual disability, epilepsy, cerebral palsy, and even death. Our world was shattered to pieces, to say the least. Following this, our doctor informed us that we could have a medical termination, or we could go on antiviral medication and immunoglobulin therapy, which would hopefully cross the placenta to the baby to lower her viral load and help stop the virus doing more damage. Our decision was a clear one. We wanted to do everything we could do to help our baby. After weekly scans, they were extremely concerned for Beatrix, and at 36 weeks, it was time for her to be born due to the increasing concerns for her life. Through an assisted caesarean section, Beatrix was born at 2.1 kilograms with a very good set of lungs on her. She was absolutely perfect. We had the most beautiful 2 minutes with her and Hugh by my side. The doctor couldn't believe how well she was doing, and he said she actually threw off her CPAP machine mask and breathed on her own within the first half hour of being born. And I feel like this really captures our little girl Beatrix because she's very determined. There was a lot to navigate in the first 6 months. Beatrix was treated with valganciclovir, which meant we had to wear gloves to change her nappies as she was cytotoxic. She had to be monitored with weekly bloods, all while we navigated the NDIS. She got fitted with hearing aids. She had cochlear implant surgery and countless scans and appointments in Sydney and in Orange. Beatrix is now 2.5 years old, and although she is profoundly deaf and has bilateral cochlear implants, we're thankful that she's been cleared of having cerebral palsy thanks to the early diagnosis clinic through the Cerebral Palsy Alliance and other disabilities. And she's thriving compared to the bleak prognosis we were originally given.
We all know we should have a healthy diet and take folic acid. We've heard we should eat deep sea fish, shellfish, soft cheese, and processed or uncooked meat. We all know we shouldn't drink alcohol or smoke cigarettes. We even know we should avoid cat litter. However, multiple international research studies report that between 61 and 87% of pregnant women have not heard of CMV, and only 1/6 of pregnant women are aware of the dangers of CMV infection in pregnancy, with research indicating that fewer than 10% of health professionals routinely discuss preventing CMV with pregnant women. Even though congenital CMV is more prevalent than the total number of children born with spina bifida, toxoplasmosis, and Down syndrome altogether, with nearly 2,000 children being born with cytomegalovirus infection each year in Australia, leaving approximately 400 children with permanent disabilities. That's 1 to 2 babies born with disabilities due to CMV every single day in Australia alone. The consequences of congenital CMV diagnosis can be life-changing for the whole family. Additional stress and financial pressure, family breakdown with couples having less time for each other, as well as physical and mental health issues are just some examples. Families can feel as if their lives have been turned completely upside down, violently shaken, shattering everything we thought we knew into 1,000 pieces, which we are then left to try and put back together as best we can. Some families mourn a miscarriage, others a stillbirth. And then there are others who might get a day or two with their babies before they die. For many of the more fragile children in their families, there are a lot of hospital stays. These families live with the constant and unrelenting fear of not knowing how long their children have. We are often left with a lot more questions than answers since there is no crystal ball for us to look into the future with. We are told we just have to wait and see. But everyone knows that living with and accepting the unknown is much more easily said than done. So our questions and fears can be relentless, particularly in the first few years. For those of us who haven't lost our babies, we know how lucky we are. But our norm becomes filled with appointments with all sorts of early intervention, therapists and medical specialists. We become case coordinators and fierce advocates for our children, cochlear implant trackers. And under the direction of our children's therapists, we also get pretty good with different types of therapy and special education. This becomes our main job, although it isn't a job any of us would actually choose. Our family's journey started after William and Emmeline were born in November 2010, when after failing their newborn hearing tests, they were referred to the Sydney Children's Hospital in Randwick for auditory brainstem response, ABR tests, when they were 3 weeks old. While Emmeline was thankfully only found to have a conductive loss, William was diagnosed with a permanent bilateral sensorineural hearing loss. Following this, the audiologist suggested we may want to test William for CMV. After 3 planned pregnancies with the help of IVF, this was the first time my husband and I had ever heard of it. William's hearing deteriorated soon after, leaving him profoundly deaf by the time he turned 1. And in December 2011, he was given bilateral cochlear implants. At around the same time, he was diagnosed with a moderate global developmental delay. Much to our excitement, he did start crawling at 15 months and finally started walking when he was 3 years old. It was around this time that William was then diagnosed with spastic diplegia, cerebral palsy, and dyspraxia. And at about 4, therapists realised apraxia and dysarthria were part of the cause for William's severe language delay. At about 6 years, he was diagnosed with ASD, autism, requiring level 3 support, followed by a severe intellectual disability when he was 7. When he was 10 years old, William was finally diagnosed with absent seizures and generalised anxiety. William is mostly non-verbal. He has a very low theory of mind and adaptive behaviour skills. And often struggles to regulate himself, resulting in significant behaviour disturbances, which can require 2-to-1 support in the community. He also has a beautiful smile and a good sense of humour. Actually, he's a bit of a scallywag. He's extremely visual and has great hand-eye coordination. He also loves his family pets, the beach, swimming, shooting some baskets, and kicking a ball around, flying his glider and being taken on a lead horse ride. Now 12 years old, it's hard to believe that Emmeline and William are almost teenagers and in high school. We will, of course, continue to celebrate everything they can do and do everything in our power to help William and his 3 sisters reach their full potential. During that first year, after William was initially diagnosed with congenital CMV, I was an emotional mess. Clearly I am right now. I often felt isolated and alone, disconnected from friends and family that were going about living their normal lives. The only people that seemed to understand were other mums who had gone through or were going through something similar. But there was no support group or go-to organisation in Australia for families affected by congenital CMV that I could turn to. I was also disturbed to find out that I could have reduced my risk of contracting CMV significantly if I had been informed about a few very simple strategies while I was pregnant. I know that I am one of many who will always wish that we had been given the opportunity to reduce our risk of contracting CMV by adhering to a few simple behaviour modifications while pregnant. We missed an important opportunity to prevent our children from contracting congenital CMV, from preventing disabilities, simply due to a lack of awareness. So in January 2012, I founded the Congenital CMV Association of Australia Incorporated with the Department of Fair Trading, and then registered it as a charity with the Australian Charities and Not-for-Profits Commission as a health promotion charity with deductible gift recipient status. Our vision,
Our vision is to minimise the impact of CMV in Australia and Aotearoa, New Zealand. Our mission is to support and empower people living with congenital CMV, raise awareness about congenital CMV through health professional and public education initiatives, and support and collaborate on leading research initiatives. We support and empower people living with congenital CMV by advocating for families and representing them in all the work that we do. We support families by providing an online peer-to-peer support group, which is a safe and supportive community for our members to ask questions, get recommendations, share their experiences and their grief, and celebrate their victories. We empower our families by providing opportunities for them to help raise awareness about congenital CMV by sharing their stories. We also collaborate with doctors to provide evidence-based information for people affected by congenital CMV. We raise awareness about congenital CMV in a multifaceted approach, sharing information across various social media platforms, providing accurate peer-reviewed information on our website, and presenting at various seminars and conferences on invitation. We created the Protect Your Baby from CMV During Pregnancy poster and information leaflet and have distributed them in health professional waiting rooms throughout Australia. And each year we collaborate with various partners, including the Cerebral Palsy Alliance, during International CMV Awareness Month in June. At CMV Australia, we also work with researchers in CMV. We are committed to supporting research which is fundamental to unlocking the answers that will help us stop CMV. It is a wonderful privilege to be able to be involved in research projects and papers that are written by amazing people who want to keep improving the outcomes and care for families who have been affected by congenital CMV. You might still be asking how and why our part in working with researchers is important. I actually thought the exact same thing when Kate put me up to it. But I can say it is so important to have our feedback and reviews of the research that is being put out there to consumers. We advocate for our families. We've been through the processes and we know exactly how it feels. It is heartbreaking, heart-wrenching, harrowing, distressing, and at times the memories of diagnoses and prognoses are traumatic. I've been working on a research paper with Professor Lisa Hui from Mercy Hospital for Women, who is a maternal fetal medicine specialist. We are currently working on the lived experience of being pregnant with suspected cytomegalovirus infection, a qualitative study of women and their partners. I was the consumer representative for the study. So my sole roles were to review the study design and interview questions, recruitment of participants, and data analysis. So, for example, I'll review the interview questions and I might find that some of them could be asked in a gentler way that is less confronting or triggering for the consumer, and I would make these suggestions to the researchers. I think that this is a really important role that we have in these studies because it adds sensitivity, empathy, and therefore the ability to collate clearer and more detailed information from consumers participating, because they're not distracted by how the questions are asked, which sometimes can come across confronting. This study has been able to identify areas for future improvement in the clinical care of women who receive a suspected diagnosis of CMV infection during pregnancy. And we are excited to see great resources and standards of care coming through for our midwives and doctors.
We are so grateful for the support of all of those who have believed in CMV Association over the years and shared our vision to stop CMV. We have amazing partners with Cerebral Palsy Alliance that we're incredibly grateful for, and the Virology Research Laboratory with Bill Rawlinson has done amazing work. We've been so grateful for all of the collaboration that we have an opportunity to help with in whichever way we can. Most importantly, we would like to acknowledge all of the families and their children who have been affected by congenital CMV. Your resilience, tenacity and strength, along with the support and respect you as parents always have for each other, constantly humbles and inspires everyone around you. You inspire us. You keep us going. You're why we're here. You are the faces of CMV, and you will always be at the very centre of what we do. Unfortunately, we can't change the past and undo the damage CMV has caused. But with your help, we will continue to give other parents an opportunity to protect their babies while we wait for the implementation of a successful vaccine. Thank you very much.
Oh, sorry. I'm so sorry. Are you amazing? Isn't she amazing? The other things that they've got on their plate, these ladies always show up and share their stories, and it's just amazing. We're so grateful to work with you. Thank you. Right. And a big shout out to the family of Kate and Hanako. What thumbs up? That's you.
Name, I have a lovely husband. What you as well. On the store to Ellen just there.
Oh. Okay. Thank you all for coming. So I was thinking about this collaboration that we have and the topic of today, working together, families and researchers working together. I was really reflecting on the fact that Cerebral Palsy Alliance and CMV Australia actually have, somewhat of a common beginning. They were both started by families. Cerebral Palsy Alliance back in 1945 was established by Neil and Audrey McLeod, whose daughter Jennifer had cerebral palsy. We fast forward through to 2005 and the Cerebral Palsy Alliance Research Institute was founded. And true to the history of the organisation and led by some of the members of the research team who are actually here in the room today, Sarah, I'm talking to you, some of the efforts were made to understand what family priorities would be for research for the Research Institute. And one priority that's repeatedly come up as an important research goal for families is to reduce the incidence and severity of cerebral palsy. This research goal or priority has contributed to the development of the Australian Cerebral Palsy Register. Collaborating with researchers from Australia and Fund for Cerebral Palsy Alliance, the register brings together data from around the country to better understand trends and rates and severity of cerebral palsy. Earlier this year, data from the CP register was used in our most recent report, and we identified a 40% decline in rates of cerebral palsy over time, and found that children born in more recent birth years were proportionally less likely to have intellectual impairment and epilepsy. These changes are not due to one single intervention. They're the result of the cumulative impact of many strategies that improve the health and care of pregnant women and their babies. And these include strategies such as our early identification of management with high-risk pregnancies and improvement in neonatal intensive care. So what about CMV? We know that CMV is a known contributing cause of cerebral palsy and other disabilities, and around 25% of children born with symptomatic CMV in the newborn period will go on to have cerebral palsy. So in line with the research priorities identified by people with CP and their families, it's been important for us as an organisation to ask the question, what's being done to reduce the risk of CMV in pregnancy? It's important because CMV prevention can be one of those strategies that reduces the total prevalence of cerebral palsy. One major initiative that you'll hear about throughout the rest of the session is the establishment of the 2018 International Consensus Guidelines and the 2019 RANSCOL Guidelines for Obstetricians. And we have people in this room to thank for that work. We have Professor Bill Rawlinson, Pam Palasanthiran, we have Antonia Shand, who is unable to be here today, Lisa Hui and Pam Palasanthiran. So many of our collaborators were key and led this important work. And these guidelines state that all pregnant women should be provided information on congenital CMV, and that all healthcare providers should be prepared to provide risk reduction information to women who are or who intend to become pregnant. And as you'll hear from the next speakers, while these guidelines are simple, translating them into practice has been much more difficult than you might think. We've used a theoretical framework called the Behaviour Change Wheel to guide our efforts in terms of implementing these guidelines. Our research group has been privileged to work with families, GPs, obstetricians, neonatologists, virologists, paediatric infectious diseases specialists, communication specialists. This was tricky for me as a researcher. advertising. I've never worked with advertisers before, and even more recently, an influencer, which was madness. And together, we've implemented a range of strategies, including seminars and e-learning programs, use of mainstream and social media, also aimed at building some momentum around this work by sharing research awareness news with others who are also committed to this goal through a network bulletin that we've developed. We've got members from across Australia, and it keeps us going because we hear about what other people are doing, and it inspires you to keep working at this quite tricky goal. I'm aware that we've got a long way to go with CMV on our CMV risk reduction journey. However, I believe that there are many reasons for optimism. Firstly, we have some momentum building. You're all here. Look at that. We have people that are becoming interested in the CMV story, which helps us to attract funding, conduct research, and get our prevention messaging out there. And we must thank Rob White and Natalia for their leadership and their support of this work. There's a strong sense of collaboration amongst people working in the field and families impacted by CMV, and this can only make our work stronger. There's new research being undertaken. For example, the NeuroCMV study, which is being led by one of our collaborators, Professor Egilmezer, is exploring whether there could be a two-hit model for CMV, where some babies are more vulnerable to this infection due to genetic predisposition. We're seeing emerging use of antivirals for both pregnant women and children born with congenital CMV. And we've established a CMV register, which will help us to better understand the long-term impact of these antiviral therapies. We now have more than 150 children registered, and we've just had some excellent meetings with the CMV Net, who are generously inviting us to join their network. We're also tracking the new CMV Victory vaccine, and I'm sure our other speakers, perhaps Professor Rawlinson, will be able to tell us more about that. But the trial is underway, and it could be a game changer for future generations of women. So I remain optimistic, and I hope you will all remain optimistic too, that we can really make change in this space. And I just want to thank all our partners and pass on to our next speaker.
Thank you, Hayley. Hi, everyone. My name is Kath Swinburn. I'm a research officer at the Cerebral Alliance Research Institute. Hello to everyone online as well. It's always tough following Kate and Hanako. I think it makes me want to pack up and get back to work. Working in the CMV space is my paid job, and these two amazing women squeeze it in around their paid jobs and their families, and it's nothing short of inspirational. So thank you. So today I would like to speak about a CMV education module that we launched in 2020. It was designed specifically for midwives. A large team of collaborators have developed and evaluated it, consisting of families impacted by CMV, researchers and clinicians, many of whom are in this room today. So you've already heard a little about CMV and the impact that it can have on families affected by the virus. You've also heard a little about the fact that CMV is far more common than most people realise. In fact, it's the most common infectious cause of newborn disability. And in Australia, CMV causes far more newborn disability than many other well-recognised about today. Toxoplasmosis and listeriosis, for example. Australia might contribute to about CMV. About 2,000 babies a year in Australia are born with CMV, and about 400 of them go on to have long-term disabilities. I always find this statistic quite shocking. And yet general awareness in the community about the virus is really low. It's shockingly low. As Kate said, some research done by our colleague Amanda, who you'll be hearing from later, in 2018, tells us that about 20% of pregnant women in Australia have heard of CMV. And we know that only 10% of maternity health professionals report that they routinely discuss CMV with pregnant women in their care. We would really like to change this. So why did we decide to make an education module specifically for midwives? Midwives are a trusted source of information for pregnant women and their families. They play a really important role in CMV education. And whilst midwives have a lot of other information that they need to do, we believe that providing information about CMV and the risk reduction strategies that we know work is really, really important. And it could be packaged up and combined, given to pregnant women alongside a lot of the other information that they're already provided with. So the eLearning course, as I said, it was developed in collaboration with midwives using adult learning principles. It's interactive and self-paced. It provides practical, relevant information about how midwives can counsel pregnant women and their families about CMV. And the content, as Hayley touched on, reflects current Australian and international practice guidelines. The course includes powerful videos of families who've been affected by CMV. And importantly, participants who complete the course are able to collect much desired continuing professional development hours. Thanks to the online nature of the course, you can see in this map that we are able to have participation from midwives all across Australia, from rural and remote areas and from all of the capital cities in all of the states and territories. You can also see that despite our best efforts with each consecutive questionnaire, that our numbers did drop off. So for each of the modules in the course, the maximum score was 5, and there were significant improvements in knowledge across all of the modules when the questionnaire before the course versus the questionnaire after the course. We did see a decline in knowledge 3 months later, but overall, for 4 out of 5 of the modules, the improvement in knowledge scores was still significantly higher compared to before the course. Awareness of available CMV resources improved from 10% before the course to 95% after the course. And you can see a couple of examples here. There are some more up the back of pamphlets and posters that our team has produced to be freely available for women and families planning pregnancy. Confidence in CMV counselling improved from 6% before the course to 95% after the course. And pleasingly, 99% of the people who did the course said that they would recommend the course to their colleagues. Thanks to generous funds from the Cerebral Palsy Alliance Foundation, from Gandel Philanthropy and from Profield Foundation, the course remains freely available on the Australian College of Midwives website. We're quite certain that we wanted to keep it free to make it accessible for everybody. And Australian College of Midwives says that currently it's their most popular freely available course. We're quite proud of that. To date, about 1,500 midwives have registered to do the course. We're currently working with the team in New Zealand to produce a version for midwives in New Zealand as well. So what did this CMV education activity teach us? It showed us that midwives who completed the course had significantly improved knowledge and confidence in counselling pregnant women and their families about CMV. It showed us that freely accessible CMV education resources combined with informed and confident maternity healthcare providers are a really strong foundation for reducing and preventing disabilities in newborns as a result of congenital CMV. But what about pregnant women who don't see a midwife or only see a midwife much later in their pregnancy? We really want to get this information to them earlier. So I'm now going to hand over to my colleague, Dr. Natalia Rowe, to tell you about our next piece of work. And once again, I'd really like to thank and acknowledge our amazing team of collaborators and the very generous funders who've helped us with this project.
So, buoyed by the success of the midwives module, the group wondered if they could do the same sort of thing to raise CMV awareness amongst GPs. And that's how I joined the team. My name's Natalia Rowe, and I'm a GP practicing shared antenatal care in Melbourne. And I think you've turned on this weather for me, so I remember when I heard about CMV in pregnancy, the devastation it can cause, and the simple hygiene behaviours that we can encourage our patients to do. It was at a webinar in late 2020, and I still have a reminder in my phone from that date with the website cmv.org.au. I incorporated the education into my antenatal spiel and found that most patients were not aware of CMV. We've already heard this. These statistics you've already heard is that less than 20% of pregnant women are aware of CMV. And that's not surprising because we know that only 10% of healthcare providers routinely discuss CMV with their pregnant patients. Specifically, regarding GPs, less than 20% feel confident giving advice and answering questions about CMV in pregnancy. GPs are the cornerstone of first trimester antenatal care. And as such, we are really well placed to provide CMV risk reduction counselling to our patients who are pregnant or planning pregnancy. But if we don't feel confident providing that education to our patients, we aren't going to do it. Our team, and you've already met Kath and Hayley, Lisa Hoy's an MFM specialist in Melbourne, Tanya and I are determined to take through education.
I've never looked so good.
So we have been very lucky to have the input of a fantastic group of GPs, obstetricians, infectious disease specialists, sexual health physicians, and families with lived experience. And we've created a 1.5-hour e-learning module specifically for GPs around CMV infection in pregnancy. So similar to the midwives module, our course offers practical advice on counselling, testing and managing CMV in pregnancy. We refer to international data and guidelines, but encourage GPs to be aware of local differences in practice. In order to appeal to a larger number of GPs, we also cover congenital syphilis. Since 2015, the notification rates of syphilis in women of reproductive age have tripled, and untreated syphilis in pregnancy can lead to miscarriage, stillbirth, preterm labour, or babies with severe physical and neurological disability. And this can all be prevented with timely testing and treatment. The course is interactive, self-paced, and accredited with both GP colleges for continuing professional development hours. I'm about to play a video that we've got in our course, and in it we've got Hanako's husband, who's a GP in Orange, Dr. Hugh Stump, and he's going to discuss how and why he incorporates CMV counselling into his consultations with his patients. So as you've already heard, he and Hanako were one of the 400 families each year who have a child born with CMV with disability in Australia.
As a medical doctor whose life has been personally affected by congenital CMV, I've been really struck by the lack of awareness among the community and fellow doctors about congenital CMV. Despite it being the leading infectious cause of malformations, stillbirth and hearing loss, we were taught very little about it during our training. Many doctors are not equipped with the knowledge or skills to discuss it with pregnant patients. The evidence shows that many cases of congenital CMV can be prevented with simple hygiene measures. We need to share this information with our pregnant women or those planning a pregnancy in the same way we share information for less common infections, such as listeria. This is how I counsel my patients. It is very common to pick up a virus during pregnancy. The vast majority of viruses are safe and do not pose any risks to the developing baby. There are, however, some viruses which, if contracted during pregnancy, may have the potential to impact on the baby's development. The one doctors worry most about is cytomegalovirus, also known as CMV. However, the good news is that with basic measures to avoid sharing saliva with young children, you can significantly reduce your chance of contracting the virus. So I recommend avoid kissing children on the lips, rather kiss them on the forehead, and avoid sharing utensils or food with young children. Also, try to remember the importance of washing your hands properly after coming into contact with children's snotty noses, their toys, or after changing their nappies. It is the small changes that can make a big difference.
We're very great. As with the midwives course, we want to evaluate the changes in GP knowledge, confidence and behaviour before they do our course and then after completing it. So as with the midwives module, there are 3 surveys that they are invited to participate in. One prior to commencing the course, where we assess the baseline metrics in respect to providing patients with CMV education and also investigating for and managing syphilis in pregnancy. Immediately on completing the course, there's a second survey containing many of the same knowledge and confidence questions, but it also asks GPs if they intend to change their behaviour regarding providing CMV education to patients. We're doing our follow-up survey at 8 weeks rather than 3 months, hoping that we'll have fewer people drop off, but we'll see what happens. And that, again, the GPs will be asked many of the same questions, and whether or not they have actually changed their behaviour in terms of the education they provide their patients. After completing the surveys, GPs are provided with feedback on their answers, and they can obtain further continuing professional development points. To put the new knowledge into practice, we give them an option as well of completing a mini audit on either CMV or syphilis in pregnancy, for which they can obtain more points if they want that. In addition to asking GPs if they've changed their management of patients, we're formally evaluating this by assessing whether pregnant women whose GPs have completed the course have greater knowledge of and adherence to CMV hygiene precautions compared with pregnant women whose GPs have not completed the course. We will also be showing pregnant women a video about CMV, so we're providing with the information regardless of whether they've received that previously. So we're still in early days, but to date we've had 102 GPs complete the course. Of those, 72 GPs have completed the pre and immediate post-course surveys, and we've only just started gathering pregnant woman data, and we've had 10 pregnant women complete the pre-video survey. We're going to be collecting data over the next 12 months. So even though it's early days, we've actually already had some really great feedback from GPs, which has been really heartwarming because it's nice to get some feedback and know that what we've done is actually helping people learn. And we're excited because this project represents the first comprehensive Australian clinical research program dedicated to embedding congenital CMV and syphilis prevention into routine antenatal care. And after this study, we hope to know that if these primary prevention strategies can be embedded through provision of online education for GPs. We're very hopeful to see the same sort of positive changes in knowledge and confidence amongst GPs that we've seen amongst the midwives. Cumulatively, this study has the potential to bring a change in routine antenatal care for the 300,000 women who give birth each year in Australia and to improve outcomes for their children. So the next step is obstetricians. We're hoping to be able to modify the course that we've created for GPs and host it on the Royal Australian and New Zealand College of ONG's website so that obstetricians too can improve their knowledge and confidence in CMV.
Yeah, I'm going to ask a question, and I'm sorry to interrupt the flow. It's been fantastic. But as much as you're doing fantastic work, I'm getting increasingly cross about why is this not being taken up by state departments of health, by the colleges themselves, by the universities, in the faculties of medicine, to be teaching this much earlier than, you know, you fabulous women and researchers having to put it out there and getting 102 GPs in all of Australia to do a course?
That's an excellent question, and you and I have both experienced that. We went through medical school and learned very, very little about CMV, and our hope is that we might end up being able to get at least GP guidelines changed, and we've definitely been in touch with the College of GPs and the College of ONGs to provide them with what we've done so far. And once we're able to publish this data, I think we'll have more evidence that that it makes a difference and that it needs to be incorporated. So we're working on it.
On the midwives front, with Kath and I contacted all the universities, and they're getting absolutely nowhere in terms of getting this course embedded in the undergraduate program. But we think it might be who you know. So they're determined. It's not over yet. And we've got a few new contacts that might help us wangle our way into some of the undergraduate midwifery around the course. Exactly. And we have met Kerry Chant previously, have we not? You might be able to talk to that in terms of New South Wales Health is interested in this topic, but just getting that sustained commitment, I think, has been a challenge. I
agree with that. I mean, it comes down to continued pressure. So I'm the University of New South Wales. Every undergraduate at University of New South Wales receives a lecture about congenital CMV. We approached the New South Wales Ministry of Health, and Kerry Chan has met with us 3 times and been very supportive of the concept of embedding this kind of knowledge in general public health knowledge rather than having it as a specific area. I think it's also important to sort of see the very positive side of this, which is that all of this information, all of this enthusiasm was locked up until about 10 years ago. And as I think Hayley showed in terms of cerebral palsy, the effects of the ability of cerebral palsy alliance and parents and people to make a difference, we're seeing the same kind of thing. I mean, you know, we now have data that you can take to public health people and which says people don't know. If you let them know, they like it and they learn. If they learn, then they reduce the incidence of congenital CMV. And anecdotally, that's what I see in my clinic, and I share a clinic with Antonia Shand and occasionally with Amanda. That's what we see. So we had a meeting in Utah about 10 years ago, and I said similar things. There's a senator in Utah whose grandchild has congenital CMV. The entire US landscape of congenital CMV has changed in that 10 years. So the sort of heartening thing is that these differences are occurring. They're occurring more generally, not just with a small group, and they're making a difference. So
There's all reason for optimism.
yeah, it's important to be angry and optimistic.
Now, I know that we've got Amanda speaking next. Do you want, are you okay to multitask?
I'm happy for a
We all want to hold the baby. I think the photo of the baby presenting definitely.
Yeah.
Yeah, that is very cool, actually.
So I'm Amanda. I'm one of the maternal fetal medicine fellows at Royal Hospital for Women, and I'm talking about a study that we've just started recruiting for, so the PIPP study, which is the prevention of infection in women planning pregnancy. And I think this follows on nicely from your question, because basically what we're trying to show is that education is important and prove that through a study rather than just anecdotally. So starting with a little bit of background, I think probably don't need to go over a lot of background on CMV because Kate gave such a beautiful talk about that before, but we know that CMV is a really important and a very common condition, and it can have significant long-term consequences. And like I said, it's common. So the most common infectious cause of disability in children in Australia. And we know that with regards to prevention of CMV, there is no vaccine at the moment, although trials are underway, and the mainstay of prevention is hygiene measures. So hand washing, avoiding sharing of saliva, and carefully disposing of nappies and wipes and tissues. Sorry, I've lost a bit of my formatting, but hopefully it's okay. So in terms of what research we've done before, I think we've already had a little bit about it today. So Dr. Antonia Shand, who's my supervisor in my research, looked at what healthcare providers know about CMV, and what we found was healthcare providers unfortunately don't know a lot about CMV, and less than 10% of maternity care providers were routinely discussing this with patients. And so then following on from this, we did a study on pregnant women in New South Wales. So we surveyed pregnant women in New South Wales about what they knew about CMV, and not surprisingly, they didn't know a lot about CMV either. And so only 1 in 6 women had actually heard of CMV. And then following on from the initial survey, we provided these women with education leaflets and then resurveyed them. And we were able to see that providing women with education did improve their knowledge about CMV. And when asked about the acceptability of those education packages, most women were happy with them and they said they wanted to know this information. So I guess what we know so far is people don't know a lot about CMV, and that's both women and healthcare providers. We know that women also have high rates of adverse behaviours, because in that second study that I spoke about, we asked women about their behaviours, and we found that about half women reported that they regularly kissed children on the lips and shed saliva, and about a third regularly shared eating utensils with their children. And we know these are behaviours that can increase risk of CMV. And we know that information leaflets can be effective at improving these women's knowledge. Following on from this, following on from this, the RANS called guideline came out, and that was the one that said all healthcare providers should routinely be discussing CMV with all women who are either pregnant or planning a pregnancy. And that came out in 2019. And so I guess what we don't know is, yes, education improves knowledge, but does that actually lead to behavioural change? And does this education then lead to a decrease in congenital CMV infection? And what style of information is going to be most acceptable in this population? And that's where the PIPP study comes in. So our hypothesis is that an educational video and leaflet will lead to knowledge and behavioural change about CMV when compared with routine care, and that this information is acceptable to planning a pregnancy. So our aim is to evaluate an education package and whether in women planning a pregnancy, it will change their knowledge about CMV and their change their behaviours towards adopting hygiene practices. We're looking at some secondary outcomes as well. So we're also looking at whether these education packages are acceptable to women, whether they cause any additional anxiety to women, what women's attitudes are about CMV and the behaviours that we're suggesting, whether they have any intention to change these behaviours. And then we're also looking at whether women seroconvert at 12 months afterwards. So that means we're looking at women who test negative at the beginning of the study, following them up at the 12-month mark and see how many of those women have contracted primary CMV during that time. And then we'll compare that in the groups of women that have the education package versus those that haven't. So we were fortunate to be able to work with an existing large randomised control trial called the PRE-BABE study, which I'll discuss a little bit about. And so we've been able to make a sub-study of that existing study. So it's a double-blinded randomised control study, and it's recruiting across 5 hospitals in New South Wales. So just a little bit of information about PRE-BABE. PRE-BABE is a study looking at whether women who are overweight or obese planning a pregnancy, and it's seeing whether a meal replacement diet program can improve perinatal outcomes. And so they're recruiting any women who are overweight or obese and planning a pregnancy. So it's a large cohort of women that they're recruiting, and they're gathering a large amount of pregnancy and birth data. And as part of that study, these women are followed up regularly over 12 months. So we've been able to use this population and use the existing infrastructure to support our study, which has been very encouraging. This is the inclusion criteria for PRE-BABE. In terms of the inclusion criteria for the PIPP study, any woman who's recruited in PRE-BABE is eligible, excluding women who don't have internet-enabled devices because the education is going to be administered online, or women who don't speak English well enough, because at this stage the resources that we're using are just in English. In terms of our methods, so at the 5-week mark in the PRE-BABE study, all women will be invited to participate in PIPP. And then they'll be randomised to either routine care or the intervention. So that's our education package. And then they'll be followed up at several increments over 12 months. In terms of our intervention, so the intervention comprises of a CMV-specific education package. And so that will include a CMV leaflet, a brief video about CMV, as well as a link to the CMV website. And routine care will just be a full leaflet about infections in pregnancy that's adapted from the New South Wales Having a Baby book. So it does have some information about CMV, but it's just the general information that most women are provided with during their pregnancy care. So this, which I think was shown earlier, is the leaflet that women will be provided with, which has been designed by CMV Australia. And it's got some information about what CMV is, how it's diagnosed, and how women can prevent CMV. And then this is the video.
Imagine a virus that causes effects in pregnancy that are 30 times more common than toxoplasmosis, 30 times more common than listeria, and is proven to cause childhood deafness and cerebral palsy. Wouldn't you want to know how to reduce your risk of infection in pregnancy? Cytomegalovirus, or CMV, is the most common virus passed from mothers to babies during pregnancy, and it largely goes undetected as most healthy people will experience no symptoms. Every year in Australia, around 1,800 children will be born with CMV. Most of these babies will not be affected by the virus. However, more than 400 babies each year will experience long-term effects, including hearing loss, learning difficulties, epilepsy, and cerebral palsy. CMV is passed from person to person through contact with bodily fluids like urine and saliva. Toddlers can easily pick up the virus from each other and generally have no obvious symptoms. Pregnant mothers and their partners can become infected from children's urine and saliva. Your risk of passing the virus on to your developing baby is greatest the first time you are infected with CMV. Women who have young children or work with them are at increased risk of infection. The good news is you can reduce your risk of CMV infection in pregnancy because washing your hands for at least 15 seconds after activities like changing nappies is one of the 5 effective ways of preventing transmission. The other ways to help reduce your risk of CMV infection in pregnancy are not sharing food, drinks, utensils, and avoid putting a child's dummy or toothbrush in your mouth. Avoid contact with saliva when kissing a child. Try a kiss on the head rather than on the lips. Carefully throwing away nappies, used wipes and tissues. Cleaning toys that children have had contact with. These CMV prevention strategies will also help guard against many other common viruses. When it comes to reducing the risk of CMV infection, search CMV prevention in pregnancy for more.
And so across the information packages, the same key messages are wash hands, avoid saliva, and don't share. And so these are the simple behavioural changes that we're going to be recommending to women planning pregnancy. In terms of follow-up, the women will complete a baseline survey so that will assess their baseline knowledge of CMV and their behavioural practices. And then they'll be resurveyed at 5 weeks to again see whether their knowledge has changed and whether their attitudes and behaviours have changed. As well, at this point, we'll also be assessing their anxiety levels following the survey. And again, at 6 months and 12 months. And then at 12 months, women who are not pregnant at that point, who were CMV negative at recruitment, we will be testing again to see whether anyone has contracted CMV during that stage time. So again, the endpoints that we're looking at, so we're seeing whether there's been a change in knowledge about CMV and the effects and behavioural change and adherence to those recommendations and comparing the groups that had the specific information versus those that did not. In terms of our statistical analysis plan, analysis is by intention to treat, and we use this hierarchy of effects model looking at how women progress from awareness to behavioural change. And so looking at whether there's been change from awareness, whether they can recall specific information about CMV, whether that changes their attitude, and then finally whether that changes their self-reported behaviour. There are some limitations to the study. At recruitment for pre-babe, women are all provided with education about important things in pregnancy, and because our team was part of the team that wrote the guidelines saying all women need to be educated about CMV, women will be provided with some education about CMV baseline because that's obviously the optimal standard of care. And so this might alter baseline knowledge. And so the control group might not have the same level of knowledge of CMV as real life women planning a pregnancy. Some women who agree to participate in this kind of research may be more health motivated or health conscious compared to the general population. And the fact that we're limiting it to women with English speaking background and access to Wi-Fi, cellular access and electronic devices also may change the baseline. So in summary, congenital CMV is a common and serious condition as we've heard today. And we know that knowledge about CMV and prevention strategies is low. And we know that education might improve knowledge and change behaviours. So we've just started recruitment, so we're in the very early stages, but we're looking forward to being able to share our findings with you. And I guess our hope with this study is that we will be able to use the results of this to develop effective educational strategies so that we can empower families and reduce the risk of congenital CMV. And I'd just like to thank Cerebral Palsy Alliance for funding this study and CMV Australia for developing those educational resources that we've been using, as well as the rest of the research team.
It is 20 to 1, so I'll go through. You've seen this. The point is that there's a lot of asymptomatic. Sorry, did you have a question?
No, you go ahead.
These are the sort of numbers you've seen. Numerically, congenital CMV is a major issue. Numerically, congenital CMV with affected, that is children who not only have infection and are asymptomatic but have some problem, is far more common than anything else. And if you think about cerebral palsy as a syndrome, and a significant number of those children have their cerebral palsy almost certainly due to congenital CMV, then it's just far and away the most important problem numerically. And you've seen this. This is the US. This is from a paper Mike Cannon and I published a long while ago. But here's congenital CMV, here's hearing disorders, so hearing loss, and here's everything else. And they just add up to be smaller. And I don't want us to whinge, because it's not a whinge, but these receive about this much more funding than congenital CMV. So you have to decide at a policy level what you do. The other thing I've already said, it's a collaborative issue. This is sort of, these are people from all around the world. I gave a plenary last year at a meeting, it was online, and I asked them what they thought the major problems were in congenital CMV, and they came up with this enormous list. What should we be addressing? And so I put them into kind of clumps of things we should be doing and we should be researching. We've got to understand the disease. We call that pathogenesis. We've got to understand the complications. We've got to understand prevention. We've got to understand vaccines. These are not mutually exclusive, but they're completely different subjects. One is media, one is people in the street, one is people in laboratories, in a small number of laboratories in the world. Why do we need to know? We know some things about congenital CMV. We know that if you test infants who've failed hearing screening, you'll find about 5 or 10% of them have unrecognised congenital CMV. We know that parents actually want to know. This is not to decry the studies that are ongoing, but we actually know that if you tell parents about congenital CMV and you provide counselling, they become no more anxious, and that's been published in Europe. We know that you can treat some congenital CMV, but it's not very good. It doesn't work in everybody. It probably reduces the risk slightly, but we do know that prevention works. You've heard several times that if parents, particularly women, but both parents understand that they need to do some basic hygiene procedures, and we just had 3 years of billions of people learning how to do hygiene procedures, so surely we can continue that. You will reduce, the figure is 40%, but let's say half. You'll have half as many congenital CMV, and all you've got to do is wash your hands and not share food. And I find not sharing food with an infant very easy. We don't know lots of things, and I could have just continued this forever, okay? There's a lot of things we don't know, but just because we don't know doesn't mean we shouldn't be doing something. What don't we know? Well, one of the things that AJ and I are interested in, Stuart Hamilton, I showed a picture of Stuart before, but is what's going on in the fetal brain and the child when the child is born, and the infant brain, is that because the virus is causing the damage, or is that because something's happening? And again, we've become familiar with COVID. You're probably all familiar that it's not only the virus, it's the response. So that's what we do as our research, and a number of people do. We're very interested in autism, and it's a very delicate area, autism in a social sense, but there's becoming increasing evidence that some autism is due to congenital CMV, and it will be the only preventable cause. And again, AJ's work is on that, and she'll talk a little bit about that. Can we reverse some of these changes? Now, I talked with Kate before, I'm just talk with Hayley. These are loved children, like my children. I love my children. But every person I've spoken to, every parent and every relative I have spoken to, it's not huge, has said, if I could have prevented this, so I listen to them. Can we stop CMV moving from the mother to the fetus? Because the mother's usually not got much of illness with CMV. In fact, probably about half of women who have CMV for the first time in their pregnancy don't know about it. They come to see Amanda or Antonia or I or Pam because they have a cold, and you say you've got a cold, but by the way, guess what? You've also got congenital CMV. So just imagine how many women are being missed. And is screening pregnant women a good idea? If you want to upset a room of obstetricians, you say, don't screen for rubella, screen for CMV. I've been thrown out of more obstetric meetings than any of them. It's true. There is one case of congenital rubella syndrome about every 3 to 5 years in Australia. One case. And they're usually from a country that does not vaccinate. The last 3 that I know of. There is one case of moderate to severe congenital CMV every day in Australia. So 1 in 5 years versus, what are you going to screen? Anyway.
He doesn't get angry, people.
No, it's logical. So I won't go through all these data, we're getting a little bit on. But the point is that we talked about stillbirth. We've had a long-standing interest in stillbirth. The most frequent cause of death up until the age of 15 is stillbirth. There are about 2,000 to 3,000 stillborn babies every year. And I don't talk about this too much, very, very emotional, but it's a major cause of death in this country, 2,500 a year. And even after post-mortem, half of those are unknown cause. And we did some work, and probably about 5% of those are due to congenital CMV, unrecognised. How does CMV get across? It's not a pathogenic. I can give a pathogenesis talk, but I don't think we've got time. The reality is that CMV gets across the placenta. So we have an opportunity to intervene. And we have an opportunity to intervene during pregnancy because there's probably about 6 to 8 weeks between when the mother gets CMV when it crosses the placenta. And this is a placenta. This is a bit of tissue that has been examined, and this is our picture of the placenta. And the point is, you've got CMV in the mother's blood, but it's got to get to the baby's blood. So you've got an opportunity to intervene. So there's a lot of hope in that, to me, that we can actually do something. We've talked about problems in babies. This is a little baby with severe congenital, what we call cytomegalic inclusion disease. This is the baby's liver and spleen, which are huge. This baby has massive bone marrow invasion, jaundiced, is undergoing phototherapy, and survived, but had a lot of problems. The point is, it's not only CMV causes these things, you've got to be able to diagnose it properly. We're in a room of people who want to hear this, but in a busy obstetric hospital and busy general hospital and busy paediatric service, you need to be able to sort this out. And so you do need better testing, better ways of testing. And of course, the most, I think it's fair to say everybody I've spoken to, but I'm sure there's somebody, but the most concerning and the most feared, if you like, complication, of course, is brain damage due to congenital CMV. It's also due to a number of other infections and another number of other causes. So you need to sort out, because you may go on to treatment, as Pam might talk about. Pam Palasanthiran is going to talk about hearing screening, but this is a paper we published with a few years ago, and essentially, and this is a paper from Dahl. This is from a Melbourne group. If you look at a group of infants who have congenital hearing loss, somewhere between 1 in 10 and 1 in 20 have congenital CMV, and it's usually almost inevitably unrecognized. Again, from another paper Mike Cannon and I wrote, this is looking at, if you screened all neonates, would it be cost effective? Because you've got to, I mean, when we're talking with governments, you've got to use a cost effective argument, and it is, just in short. So Adria's going to talk a little bit about her work.
So sorry, Bill. Thank you very, very much.
So Adria's going to talk about her work on CMV the brain.
Yeah, hi everyone. My name is AJ. I'm in my final year of my PhD, hopefully. And my research sort of focuses on investigating the effects of CMV infection in the fetal brain. So as you've probably heard many times before today, I'll just reiterate, cytomegalovirus is the leading non-genetic cause of fetal malformation in developed countries like Australia. 60 to 90% of children with symptomatic infection and about 10 to 15% of children with asymptomatic infection then go on to develop neurological illness. So on the left, we've got some CT and MRI images of the brain of infants congenitally infected with CMV. And some of the neurological symptoms include microcephaly, developmental delay, sensory neural hearing loss, and cerebral palsy. However, despite the significant impacts of congenital CMV infection, we still don't fully understand how the virus causes these symptoms. So for us to study the effects of CMV infection in the developing human brain, we need to use an appropriate model in the lab. Traditionally, animal models are used. However, you can't really study a human virus in an animal model in an appropriate way. So for my PhD, I generated something called cerebral organoids, which are essentially mini brains that we make in the lab in a petri dish from stem cells. They end up being about the size of a pea and mimic human fetal brain development, complete with different cell types like neurons, and include different brain regions like the cortex. So this is an image of one of the cerebral organoids that I generated. So essentially, it's just a very good model of the developing human brain in a petri dish. It takes about 60 days to make. That's nice. But so circled here in blue, you can see these are neuroepithelial rosettes or tubules, which you would also expect to find in a human brain. So it's very promising when we got the, yep, this looks like a brain confirmation email and a bunch of other tests that I had to do. But cerebral organoids have already actually been used to study a number of other neurological illnesses like Zika and SARS-CoV-2. So this seemed like a great model for us to do CMV work. So the purpose of making these organoids is to infect them with CMV. And on the bottom left, you can see that we did that. So this is just one of the very blurry image of an organoid, but the cells that are red are CMV infected. So far, we've identified that CMV infection actually significantly affects processes involved in neuron development, which is obviously very important in the developing brain. We've also done some RNA sequencing that have shown that some autism spectrum disorder-like phenotypes are associated with the infection of CMV in organoids. It's a bit of a delicate area, but it's looking like this might be a potential cause. That one of our main research areas focuses on developing antiviral therapeutics. So as we know, pregnant women are unfortunately a significantly disadvantaged population in terms of therapeutic development due to the obvious ethical limitations involved in clinical trials. And unfortunately, there are no current available CMV antiviral therapeutics available to use during pregnancy. So we thought it would be a good idea to use these cerebral organoids in the lab to see which antiviral therapeutics that are available actually do help resolve CMV levels. And here you can see this is very preliminary data, but there's some promising data. Some of these antivirals are actually very good at lowering levels like acyclovir. And we intend to continue using this model to test the safety and efficacy of these drugs. We're also going to continue the research to see if these antivirals can potentially reverse the effects of CMV we're seeing in the organoids, and that can help us better inform future clinical trials as well as drug development with our collaborators in Germany who do test a lot of really interesting compounds. Just kept it short and sweet. So.
And I'd just like to emphasise growing one of those organoids not only takes 50 days, but it takes an awful lot of experience and an awful lot of hard work. And I think this is the most important message perhaps of the day to me. Pregnant women are disadvantaged because you can't do trials. The FDA specifically eliminates some trials, and the US is one of the largest generators of new antivirals. The Australian TGA specifically won't take pregnant women into trials. This is just to show you this rubella vaccination came in the sort of 70s and 80s, and congenital rubella syndrome and rubella disappeared. But it took about 10 to 20 years because you were vaccinating young girls, young women, and then they were not pregnant for 20 or 30 years. So it took quite a while. The last thing I thought I'd talk about was vaccines, because I think it's important to have a sort of on the front foot positive attitude to this. Recently, with a guy called Suresh Papar and an international group, the WHO had what's called a Vaccine Value Project, or VBP, and they asked a group of people who were, very diverse internationally, what they thought they should be developing vaccines for. And at the last minute, CMV was included, and it's one of 15. And so we wrote up a profile, if you like, why you should have a CMV vaccine, and that's just being published with the others. But I'd like to emphasise it was 1983 when a WHO body said a CMV vaccine is one of the highest priority vaccines that should be developed. In 1983, I just finished medicine 40 years ago, and it's taken until this year for the WHO to acknowledge it is one of the 15 most important, and hopefully with the work that a number of companies are doing, and I have no interest in the companies, but particularly Moderna and GSK, and as you're all aware, they've been developing mRNA vaccines. I met with them 10 years ago. I met with Moderna on an advisory group, but who you give them to, how they accept it, all that's got to be worked out. But it's being worked out, and the vaccines are being trialled at the moment. So I think that's very positive. That will see, if it's effective, as I hope, the end of congenital CMV. Simple as that. This is, I've asked the permission of this mother and father this is from a long while ago, but this is sort of story, with all due respect to everybody here, that I got sick of hearing. I never wanted to hear again. Not because I'm not empathic, not because that this is not genuine, but this is what so many people have said to me. I wish I'd never heard of CMV. Well, unfortunately, it's the most common cause of congenital malformation in this country. So everybody's got to know about it, and everybody's got to do something about it. And when we do that, and when we have a vaccine, it'll stop. And these are for this talk last year, I asked Kate and I asked Sharon, was the CMV action in the United Kingdom, and Janelle Greenlee, who some of you know, is a bit of a live wire, and Kristen Spytek. I asked them what they thought, and I've highlighted what I thought was the most relevant thing. And Kristen, I really like, the time's now. The time for talking about this and the time has gone. So thank you very much for all the collaborations that we get from all of you and from other people who aren't in the room. Thanks to the Cerebral Palsy Alliance for inviting me to speak, and thanks for your attention.
We do have one question from the chat, if that's
Yeah.
all right. So Katie has said when talking about the possibility of reversing the effects of CMV, would this be before birth or after?
It'll be before birth. Pam will talk maybe a little bit about some of the ones, but there are a lot of problems with with treatment after birth. The antivirals that AJ mentioned, the most effective of those are quite toxic, but we're talking about manipulating, if you like, changing the environment for the fetus to be better so that the baby doesn't get so infected in utero.
Thank you.
Okay. Firstly, thank you very much, Hayley, and Cerebral Palsy Australia for inviting me here. I think it's just incredibly inspirational group here. So thank you for sitting through. Next, thank you, Kate and Hanako, and people like you for sharing your stories, because you're courageous and you actually put a face to congenital CMV, which makes awareness impacts a lot of awareness, and actually just feels our passion for continuing our work in CMV. So thank you. I realize how hard it is to share information. Just a small thing. Bill didn't say this, but Bill and I occasionally, I'll keep it up a bit now, putting in a lot for grants for some of our CMV work, and sad to say it's not sexy enough to actually pass some of the grant applications we've given. They've given a lot to COVID, for example. So that's kind of the background that we're sort of working with, and we're so grateful for Cerebral Palsy for some of the support you've given us. So that's my bit, and hopefully this works. So just so a bit about myself. I'm a pediatrician, infectious diseases, and I've worked in congenital CMV for last, my God, I'm counting out 3 decades now. That means, Bill, you and I have worked together for 3 decades. So there we go. So our first babies, not ours. So why am I here? Bill set the scene for us. So it's kind of to tell you about, I'm a clinician researcher, so I actually do clinical work, and I try to do clinical work that impacts and translates to better clinical care. So I just want, it's a good story. We at our site with all this collaboration and Bill from the pathology services, have always been trying to actually better detect congenital CMV from children who are identified as having hearing loss. So you need to know just a little bit of background. You know that congenital hearing loss, not congenital CMV, congenital hearing. So being born with a hearing loss, a permanent hearing loss related to a nerve problem, it's not that uncommon. So it's 1 to 2 1,000 pregnancies of babies delivered per year. And we know, and now we know in the last 10 to 20 years, sorry, about 20 years, that we've got a newborn hearing program. This was just only introduced in 1993, and the uptake has been enormously successful, more than 96% uptake. So babies are screened for hearing loss. So screening is operative, not diagnosed, but screened for hearing loss in the first, when they're born, the newborn period. And we know this figure, about 1 in 5 of babies with outside hearing loss.
If you manage to constantly offer both, you manage to
usually. After 3 years of COVID, you learn how to do the background check noises. So, but the other thing you need to know is that in terms of opportunity for testing, you have to diagnose you have to take the samples from the babies, and in our case, be urine or saliva, and that sample to test for CMV has to be done within 21 days. Otherwise, you miss an opportunity, and then you can't tell whether or not that CMV has infected the baby after birth. So it's called postnatal. So that hold that thought in your mind, because that's kind of what's driving the need for timely diagnosis. Just a little bit of information. This is how we collect the saliva swabs, just a viral swab. It's very simple, but you need to do that by at least an hour after breastfeeding the baby, because breast milk does contain CMV. Then if it's positive, you don't know whether it's the breast milk or the baby is infected. But this is the method I like, we like, because it's not fraught with false positive, and that's basically taking urine from babies. Some of you in the room would probably have had to take urine from your baby, and then they put this really horrible plastic stick on bag, collect urine and send it off. And Bill and I have had one scientist help us out with actually seeing whether or not putting cotton wool in nappies are feasible, and it's good. And so we actually saw that that's actually for congenital CMV, you can actually test that urine that's identified from cotton wool. We didn't really go on to a bigger study after that, but that's kind of, so I thought that was a really useful practice. It's not for diagnosing normal urinary tract infection, please. It's just because that one you need clean urine. This is just okay for a simple virus like CMV. Anyway, very quickly, this is for those who've had children in the last 10 years, 15 years. So anyway, since newborn hearing screen, this is what every baby after birth will go through. They'll have a hearing screen. It's not a diagnostic screen. It's a hearing, just a screen to see whether or not the baby can hear. It's not an invasive test, so it's very acceptable. It has to be performed by a trained screener. The baby has to be in a resting or in a sleep state. And basically, they put a very soft earphone, like your teenagers have walking around. And then they put a soft clicking sound in there, and then they measure the response of the baby. So that's just called autoacoustic emission or AABR. That's just a screening test. So the results are known immediately, and the baby doesn't pass the first test, which is usually in the first few days of birth. There's a second, so it's called a refer one, and then you go to refer two. You do another one several days later, because most of the time it's fluids there. So that's what a refer is. If you pass, the baby passes, baby's got normal hearing at the time of testing, because you may not have got the message there, or you will have got message. Some babies with congenital CMV are born asexual, right? You can't tell that they've got CMV, but they develop 10 to 50% will develop later onset hearing. So that's all really, really important to try and diagnose congenital CMV in these babies who, congenital CMV really. If both screens are passed, we have a refer for diagnosis. So that translates to this kind of a simple testing flow chart where you have the baby's birth. So we don't do universal testing, and I don't think that's coming in the near future. But you can test the baby here, the second refer, so that baby, that in theory is within the first 21 days, but it's not always the case. In big centers it is, but it's not necessarily so if you're from a rural site or whatever. So this looks a very clean diagram, but in general, there are a lot of steps that could actually, hinder all this being done within 21 days. But anyway, if you fail the second refer, the baby gets a diagnosis sent to an actual audiology test. So, but what the problem here is that routine testing for CMV in any of these sites, whether you have a second refer or whether you have actual hearing loss, is not routine. We do it because we know, we engage, and we want to test the babies. But outside in the German community, we're not talking about America and the US, but certainly Australia, it's not routine of care unless you actually have people like us who are engaged and we actually have put a pathway in. So what have we done? Basically, before up to 2018, we together with Bill Slad, this is how we have to do this in the clinical sense. So we don't have money to do research, but we do it in the clinical sense. So we did a clinical diagnosis. We were only testing after the babies had confirmed hearing loss, late, because most of them after 21 days. So you can set the scene. This is what we did. This is our own pathway. And this is what we found. So just concentrate on this part. We found that we could only doing that way after your hearing loss, because they come later in 20 days, we only caught 40% of babies in time to accurately test for CMV. So what did we do? So we moved further forward to the last few years. We changed our practice. Like in some parts of the world, we've gone to time that's changed. Now we are testing babies for CMV a little bit earlier at the second refer. Now, not all of them will have hearing loss, and not all of them will have CMV, but we have actually been able, what we're doing is we're doing this timely testing, and we've done it before the 21 days. So that's the issue. So if you don't diagnose it by the 21 days, and you miss your opportunity, what you've done is actually there's a problem with clinical care. You can't give the parents an accurate diagnosis. They'll say, well, how do you know? Baby's now 40 days old, you've got CMV, is it actually postnatal? If we do it over here, we can just say confidently, look, we know Bob's got congenital CMV, and we now can either offer treatment or, but more importantly, we offer counselling, and we do more frequent tests. I won't tell you what, so there's a clinical impact for all this. So this is what we're doing now. So I love. Please tell me you love the name Catch by 22. Yes, great catch name. Yeah. So this is what we're doing. Remember, this is a single site, Royal Hospital Women, and I won't go through all the flow so you can read, but we really have a very good process in place now, and we make sure that we've got lots and lots of notification. we give a fact sheet to the families to say why we're testing. If it's CMV, we will call it, we'll give the results, so on and so forth. And very importantly, everyone in this flowchart, all the multi-Ts are very engaged. And that's almost one. So they're very, and that's why the system works. And look, this is the old chart you just saw. This is now what we're doing. We're actually testing babies appropriately early, 90% of the time. So we've doubled our capture rate. And what that's meant is that we've been able to, that the families have benefited from this, but they've actually got information that's directed. Been doing it for 4 years. COVID did what it does to everybody in that time. The screening process was actually chaos. So we haven't actually got very good data. You know, you can't come in, you've got to wear masks. They won't allow the mothers to come in, the babies, all that sort of stuff. You know, really independent clinical care. But we're continuing the data, continue to get the data. We also have the old method still being used because the audiology service, they don't test only the babies from the Royal Hospital women. They also have referrals. They have a catchment area, and in that group is following the old practice, and they're still only discovering, or we're only able to diagnose congenital CMV 30% of the time, 9%. So take a message that with a very engaged group of people, good communication, having really leaders and a committed team, we're actually able to impact on practice. So I think that's my, and I really would like to take everyone through the field for in your lab.
I just got another question from the chat. This is from Melissa. Can I ask, why do you say that universal testing won't be coming in the near future?
I just think that, you know, it's cost, it's all about politics, people getting angry, having someone interested in your cause. Bill has already alluded to, we've gone many times to Department of Health, they've not been very interested in sales. We haven't really had the buy-in, and I think it's just the cost, you know. I think there's something called Jung's, there's 7 things with the Jung's criteria, where if you introduce universal screening for something, you have to fulfill 7 criteria, and one of them is actually there's something that can be done, there's an intervention that can be done. I mean, we will say yes, there's interventions, you get the diagnosis, you can follow these babies. 10%, they look normal, but, you know, like they might get hearing loss and developmental. It's just not cost effective enough. Early intervention. That's right, exactly. Exactly. And you've got hearing loss, you actually can get NDIS funding. So there's so much of impact on it, but it just hasn't interested colleagues. Thank you.
Yeah, so hi everyone. Last presentation for the day, I believe. My name is Max Weber. I'm in the marketing communications team at Cerebral Palsy Alliance. And in this role, it's a really great pleasure, perhaps the best part of my job, that I get to work really closely with the research team on a wide variety of really exciting projects. Perhaps the one that I spend the most time on is CMV and raising awareness of CMV specifically. So I started at Cerebral Palsy Alliance about 2 years ago, April 2021. In my first week, my then manager said to me, "Can you sit in on a meeting with this researcher? She's really persistent. She doesn't stop banging on about this acronym." And despite my wife being in her 3rd trimester of pregnancy at that point in time with our first bub, that meeting with Hayley was the first time that I had ever heard of CMV. I think I've learned since then that that's actually a really common experience at Cerebral Palsy Alliance. You started CPA, being familiar with the CPA acronym, and very quickly Hayley will get to you and you'll very quickly learn what CMV is. Unfortunately, that's not really a scalable system of raising awareness of CMV. I think probably maybe, you know, there's probably several thousand people at this point in time that had that meeting with Hayley. But to get to those other, several million people that we need to raise awareness of CMV, from that point onwards, I've worked really closely with Hayley, with Kath, the wider research team, and also my colleagues at CPA and our fundraising team, the Training Alliance team. There's a whole kind of set of divisions at Cerebral Palsy Alliance that kind of mobilise around kind of April, May to start planning for the CMV Awareness Month. And like I said, it's a really great privilege of mine to be able to work on that as well. I won't dwell on this slide because I know everyone's got a very clear grasp of CMV by now. I think this is probably the 5th version of this graphic that we've seen today. But for me, it does drive home just how impactful that stat around CMV being magnitudes of all of these medical conditions that we all know really well, even if we're not remotely close to the medical field, like rubella, listeriosis, etc. So that was the first thing that grabbed me when Hayley told me about it. I think it kind of sticks with me, and you definitely like to share that. So what I do want to share, what I do want to talk about today, to kick off is the results of our very first CMV index, which again demonstrates the scale of the problem we're trying to solve here. So in February 2023, February this year, we've obviously been doing CMV Awareness Month for a number of years now, but we really wanted to set a benchmark that was a population level study of the awareness of CMV. So we put a national survey into the field. We had 500 responses to that survey, including 360 women who are either currently pregnant or planning a pregnancy in the next 12 months. It was a population level survey. We worked with a reputable market research agency to put this into and what we found is that only 14% of women aged 20 to 40 had heard of CMV, and that number rose a little bit when we talked to pregnant women or women planning pregnancy. It rose to 18%, which I think is reasonably consistent with some of those stats that, again, we've heard today. Different researchers have conducted research in this space. But, essentially, we had to ballpark it. We're looking at about 8% of the population at least who haven't heard of CMV, who we need to get to. That demonstrates the scale of the problem. Luckily, our task is quite simple. We need to raise awareness of CMV, and more importantly, we need to raise awareness of, again, through line of today is that there are very simple preventative measures that we can encourage people to take that reduce the risk of CMV. Again, we know from the survey that we put into the field in February to March that a significant proportion of Australian women aren't doing those preventative measures. So again, this just paints that picture to get them to implement these behavioural change, I suppose, strategies. We've got a lot of work to do. So that first CMV index will act as a benchmark for us throughout the coming years, so we can see how we're moving the dial when we talk about CMV awareness. So in a nutshell, our strategy is to leverage the period of June, which is CMV awareness, as a key campaign period to raise awareness of CMV and of those behaviour change strategies. Just briefly, what we learned last year is that we know that our message, once we can get it to people and to the right people, is really compelling and really empowering. Something a few people talked about today, that when families get told about CMV, they don't pull back from it. They're usually quite empowered by that knowledge. And so in order to tell them about CMV, we need to get the message to them in a way that cuts through all of the clutter. One of the big campaign insights that we've had in previous years is that talking to pregnant women, as everyone in this room knows, is very difficult because the magnitude and the number of people trying to serve them public health messages, but also, it could be anything from nappies to vaccines to things you need to do as a first-time parent. They are overloaded with so much information that what we need to do is make it memorable and easy to act upon when we share these campaign messages with them. Kath's pointed it out, Tali's pointed it out. We're also very keen to focus as a secondary key group that we're trying to hit is that maternal healthcare professional space. And so kind of a secondary component of CMV Awareness Month is using those e-learning courses. For several years now, obviously, the midwife e-learning course, but then latterly the GP e-learning course. That's a component of our campaign as well. Obviously, those maternal healthcare professionals can have a really outsized impact in sharing our message. So essentially what we're trying to do is run a public health campaign at a national level on a shoestring budget. For 2023, these are the people in the room. These are the group of agencies and non-profits and charities that work with. Obviously, Cerebral and CMV Australia, very well known to everyone in this room. Most of you have some very formal affiliation with them. We also work with Good PR, which is our CPA's PR agency on retainer. And from a digital and creative perspective, we work with Media Precinct and their creative agency Resolve on advertising. We have a two-pronged approach to CMV Awareness Month, and this strategy gives us best bang for buck and also the best opportunities to reach the most people where they consume media. So the first is what we call jargonistically earned media. This essentially means getting our message out in the news, TV, radio, newspapers, online media, wherever people are consuming the media that they consume. And the second is paid media, and that's advertising, where the focus is digital advertising. In this instance, as it's a very cost-effective way to get reach at scale, which in the first instance is what we're trying to do. You can't tell them about preventive measures if they don't know what CMV is in the first place. So it's a very cost-effective way of reaching out audiences. As Hayley alluded to right up top, for this year, we also implemented our first kind of influencer campaign. We've been working with a Mums and Bubs publication called Kindred, which has a really big national footprint to share the CMV message through their channels. And specifically, we've been working with a midwife called Lazzaro. Her account has over 80,000 followers. And obviously, being a midwife, she has that trusted kind of, that's validated in the eyes of either pregnant women or women who have young children. The vast majority of which are, follow her for her opinions on things like, health. So that's a really kind of outsized focus for us in 2023. There are some examples here of the creative that we've got in market at the moment. You can see the look of the appeal. The messaging of our campaign, which is out in the wild at the moment, is designed quite explicitly to appeal to, again, that target audience, women 20 to 40. We know what kind of media that they consume, and we also know what appeals to them. And we've sense checked these with a lot of consumers, and we've had some great involvement with consumers in the room. So Kath and Hanako have been to some workshops, and also some other families have been involved in helping us to fine tune these messages. And the message, as you can see here, probably a little small, but there are enough screens around the room that hopefully there's one close to you. We have a really three-pronged kind of very simple call to action, which is watch with care, kiss with care, and don't share. And you've heard this today from Professor Rawlinson, you've heard it from everyone so far today. I think we all know what those preventative measures are. The problem is that the vast majority of people seeing these ads don't. So the ads are designed to be compelling, to grab people's attention, to stop them scrolling, and then to get them to start to take these behavioural change steps. So this is something that we've been finding in previous years. We've been serving up some iterations of these messages for several years. But 2023 is really the first time that we've kind of pulled back and taken a lens. What is most appealing to young mums? What's going to get best cut through? What's going to get them to actually buy into the message and perhaps retain it longer than some of the other things that they've been told about as first-time mums, people planning pregnancy, etc. So at CPA, and again, this has been alluded to several times today, I just want to kind of reiterate from a communications perspective, from a PR perspective, I suppose, principle that I run my job through at all times is we need to be led by lived experience. Everything needs to be centered on lived experience. We know that's where the most powerful stories are, and we know that that's where that's what really helps to inform people most effectively. Kath and Hanako giving a face to CMV, as I believe was referred to earlier today. So our approach is always, when we're coming up with campaign strategy, the first thing we do is we speak to families, we get the buy-in from the families, we ensure that they're comfortable with our approach, and that we have their kind of blessing to take this approach to any kind of PR campaign, any kind of media campaign. That's just not CMV, that's everything we do at Cerebral Palsy Alliance. And then what we do, that's the most important pillar. And then the second pillar is we augment that with expertise. We augment it with researchers, with medical professionals, with Hugh, with Hayley, with Professor Rawlinson, everyone that has that, that established credentials in that space. That kind of 50-50 approach is really where we try to be. That's where our sweet spot is when it comes to PR, when it comes to communications. So that CMV journey is really, really powerful. And we're incredibly grateful to Kate and Hanako, and there's dozens of other families who entrust us to tell their stories in an empathetic way. And the most important meeting in the CMV campaign planning calendar is in about mid-April. We get on a call with CMV Australia and basically say, who have you got? Which families are sticking their hand up? Who feel comfortable doing it? Where are they based? What platforms they feel comfortable? Do they not want to do TV? Is that too in your face? What nuances do they have? What are they worried about? What don't they want to talk about? Just really making sure that they feel like they're being supported, because otherwise that campaign's not going to work if the families aren't feeling like they're supported throughout that. Nuance is also incredibly important when it comes to PR. It's very easy, and we've done it in previous years. It's really easy to generate a story where the hook is, horror virus your doctor didn't tell you about, which is great for a headline. But beyond that headline, we need to go into those key messages. We need to ensure that the story is balanced, because, we spent 2 hours talking about CMV is pretty nuanced. There are a lot of things we don't know about it. There are a lot of things that you can't get into in a 400-word article. So we need to ensure that we're working with trusted media partners who are able to convey that message for us to a mass audience in a way that isn't jarring, is not exploitative, and that's actually a really narrow needle to thread. So it takes a lot of work when we're talking to journalists about this story to ensure that it's not sensationalist and actually does what we need it to do.
Excuse me, Max.
Yes.
Sorry. Just 2 quick questions. Sometimes don't you need it to be sensationalist?
Well, we have no problem with getting the sensationalism. It's the follow through after that. So for that late approach, Helen, I know as a journalist, you're very, very familiar with that. But
I do it sensationalist. Some of my colleagues do.
But we've got some examples of that. Actually, I'll play a video now that hopefully demonstrates the kind of approach that we try to take, the kind of messaging that we try to nail. So this is, and these are some examples of some of the media that we secured. So again, you can see that headline. Sometimes you can't convey everything you need about CMV in a strapline. So it's ensuring that the story is balanced, led by the families, which also brings people in and really grabs people. It's compelling, but then it does what we need it to do from a public health perspective. So that's something that we've been spending a lot of time on in the last few years. I just want to play a quick video now. This is an example of a story that aired on 7 News nationally earlier this month, and this is the kind of things that we're trying to amplify throughout CMV Awareness Month.
When Joanna was pregnant with Tilly, she did everything by the book.
I avoided soft cheese, I avoided sushi, everything was normal apart from a bit of a cold.
It wasn't until her daughter was 4 months old that she started noticing developmental delays.
I guess I just had a gut instinct that there's something more going on here. At 9 months old, she was diagnosed with cerebral palsy.
Joanna had passed on something called cytomegalovirus, or CMV. It's very common and presents with symptoms similar to a cold, but
if you get CMV for the first time during pregnancy, you have a high risk of that virus getting across the placenta from the mother to the baby.
Around 2,000 Australian babies born each year will contract CMV in the womb. Of those, around 400 will have a disability, and 1 baby a week will die from the virus. Yet fewer than 1 in 5 women have heard about it.
Often CMV goes unrecognised and undiscussed.
I had no idea. It was complete news to me.
But there are some simple steps to prevent infection. Washing your hands regularly, kissing your kids on the forehead instead of the lips, and avoid sharing food and cutlery. As for how Tilly's doing now...
Hey, I'm 10 years old. She's 10 years old now. She's a ray of sunshine. Except what?
I scream and cry.
Yeah, sometimes she screams and cries. I think all kids do that, don't they?
Jacinta Lee, 7 News.
So Joanna and Tilly are our stars. They were kind of our centerpiece for this year because we like to keep it fresh. We like to introduce new families into the mix. And a good example of how we kind of have this wraparound policy at Cerebral Palsy Alliance, where we really try to leverage all of our touch points. Tilly is also going to be one of the, I hope I'm not letting the cat out of the bag here, Joe, but Tilly's also going to be one of the faces of September this year. You know, we have this great scale of capability at Cerebral Palsy Alliance where we can do things like that and, you know, continue to share that CMV message throughout the year. Obviously, we're still in June, so these are only interim results. We don't have the full kind of set to share with you, and particularly when it comes to digital, the picture is quite incomplete. But we have had some really strong interest. This cumulative reach is across all channels. It's a little bit of a fuzzy number, but we can certainly say that we've generated 88 individual pieces of radio, TV, etc. That number is actually going to tick up. In fact, as we speak, there's a family. Pan is on Sky News down in Canberra at the studio talking about CMV to another new audience. So that number will continue to tick up, you know, hopefully into July, even as we do some wrap up media around CMV. Again, from the digital perspective, we're seeing really strong results in terms of website traffic to our landing page, which has all of the resources, all of the information to share with families. It redirects maternal healthcare professionals to the training modules that they can get access to. And it has all of those resources that are out on the tables at the back there, the pamphlets in multiple languages, the you know, the fact sheets, the infographics, all of the things that you need to really tool yourself up on CMV. So I can't speak to the results in any huge detail yet because we're still in the middle of CMV Awareness Month. But you know, anecdotally, I think we're seeing some really strong results. And you know, this doesn't just end when the month of June ends. This is what we call an always-on campaign, which basically means that it ticks over throughout the year, and it's something that's always a priority. We're always investing in it. You know, Hayley's always hassling people. We'll continue to share the message, and particularly target midwives and GPs with that e-learning course is going to be a continued focus for us throughout the rest of 2023 and into future years. So I think it's getting some really strong momentum. It's really exciting for me to be able to work on it. It's a really powerful campaign, I feel, and the wider community certainly starting to take note. And I'm sure, not to speak for Rob, who's just had to step out, but given it's a causal factor in, you know, at least 10% of cerebral palsy, I'm sure that, you know, CPA is going to continue to have a focus on it for the coming years. That's me, everyone. So thank you for taking the time over your lunch break. That's me done. Thank you.
I just want to say thank you to all the presenters who gave their time and to come and present today. And we all really appreciate all your contributions and hard work. Could we have a little... just that I want to say that Cerebral Palsy Alliance is really proud to be working in this area, and that we look forward to continuing our collaboration with everyone in this room, and appreciate all the support that you provide to us. Thank you very much.
Thank you.